How's it going, guys? My name is Kyle Probst. I'm an officer here at the Palmer, Florida Gonstead Club, and today we're going to be going over atlas and occiput. We're going to cover the anatomy of these bones, how subluxations happen here, the misalignments that are caused from these subluxations, and then the nerves that are affected from the subluxations. So let's just go into a little bit of a brief overview first. So we know that at the rest of the spine, the subluxations happen at the disc level. The swelling of that disc from the nucleus pulsus moving in from the annular tears will cause the vertebrae to move and misalign, causing nerve pressure and then the symptoms that you may get from that. But here we have a little bit of a different story at the atlas and the occiput, and that's based off of anatomy. So if we look here at C2, this is C2 right here. You can tell that by the odontoid process, or the dens that is sitting right here. And this odontoid process gets in the way of us having an intervertebral disc. As you can see, it takes up a large amount of space because the atlas will rotate around this odontoid process, or the dens. So it's impossible for us to have an intervertebral disc like we would have here at C3. So instead, we have capsular ligaments on each side. And when these capsular ligaments swell, that will put pressure on the nerves surrounding the structure and also will misalign the atlas. So when this, right here at C2, when this capsular ligament will swell, on either side it can happen, it'll cause this atlas to misalign and move around and will cause subluxations to happen. But here we have the same idea. We have capsular ligaments on top of the atlas that will make the occiput misalign. And so we'll go into those occiput and atlas misalignments right now. All right, so let's get into our atlas misalignments. So like we said, when the capsular ligament swells, it's going to cause that atlas to become misaligned. So the first direction that's going to do that is anterior. It's kind of hard to see with this model moving around like that, but the dens right here, the odontoid process, is going to prevent this atlas from moving posterior. So the first direction it goes is actually anterior. It's the only vertebrae that does this because of the dens. And so after it moves anterior, it can go either AS, which is anterior and superior. For that, we reference that anterior tubercle right here. That's the anterior tubercle. It's kind of hard to see on this model. But if it goes anterior and superior, that's AS. Or if it goes AI and drops down, the anterior tubercle drops down, that's an AI atlas. And so typically when we find a true atlas subluxation, it is going to be an AS, but we always want to double check and make sure that we use our whole Gonstead analysis, and we use X-ray to find if it's an AS or an AI. That allows us to be as specific as possible. And when I mean a true atlas subluxation, I mean that it's not compensating for anything. Dr. Gonstead talks about in the chapters that 82% of atlas subluxations are compensating for something that's happening down below. So we want to make sure that we check the structures below and make sure the foundation is correct and that the atlas doesn't have to compensate for anything. So moving on, we talked about it going anterior and then either superior, inferior. Next is the laterality, whether it's moved to the right or to the left. Again, it's kind of hard to show on this model, but the laterality like that. And then the rotation, whether that side of laterality has gone posterior or anterior. So let's say, if I can get this model positioned correctly, we have an AS, it's gone anterior, superior. Then we have a right laterality, it's moved to the right, oops, to the right like that. And then it can either go anterior or posterior. And for that, we reference the transverse process right here, whether that's transverse process is tucked back posterior or gone anterior. So an ASRA is going to go anterior, superior, right laterality, and then that transverse process on the right side is going to go anterior. Okay, now let's go on to occiput misalignments. So we especially want to make sure that we understand the anatomy of this joint. This is the atlanto-occipital joint. And so we can see here that it's kind of like a kidney bean shape, right? It's not just flat. It's not flat, it's cupped. And it's a cup that's kind of almost at an angle. So this allows for the occiput to rock back and forth like that, and like that, which you can see from the condyles right here. The condyles fit perfectly into this joint to allow for that rocking forward and backward motion. So when the when the occiput misaligns, you can go PS or AS, and then that capsular ligament a capsular ligament, when it swells, it can make the right side superior or the left side superior. And then just like in atlas, our last part is that rotation. So if it was a PS, that means it's gone posterior and superior. RS, that means the right side superior. Then it would be either RP, it's gone backwards, or RA, based off of that rotation. Again, this model is kind of hard to see things on, so get a buddy and practice these misalignments and just focus on this joint and how that works. All right, guys, so we discussed the anatomy of the occiput and the atlas. We discussed how subluxations happen with a capsular ligament rather than an intervertebral disc. And then we discussed the misalignments and the direction of those misalignments. So now let's talk about the nerves that are affected. So remember that with the atlas and the occiput, we're working in the parasympathetic region. That's parasympathetic region is a part of the autonomic nervous system. It's from occiput to C5 and then the sacrum. So with atlas subluxations, it's going to, of course, affect the spinal nerve that's right there, but it can also affect the vagus nerve or cranial nerve 10. And remember that cranial nerve 10, the vagus nerve, innervates our organs. So if your patient presents to you with visceral issues and you've checked the upper dorsals, you've checked the thoracics, you've checked the rest of the spine and everything, you don't find anything else, check up higher. And if they have an atlas subluxation, that can be causing those visceral issues because that vagus nerve innervates the heart, the lungs, the stomach, and organs of that nature. So if we take a look here at this picture, and I turn the light off so you can see, I've got the atlas. We're looking at a top-down view again of the atlas. And this nerve here in yellow, if I can get this right here, the nerve here is the vagus nerve. And so you can see just off of the anatomy, it's sitting on the anterior side of the atlas. So if this part, this left part of the atlas was to move anterior, that would run into and put pressure on this left vagus nerve. Same thing, if it was an RA atlas and this right went anterior, it would put pressure on the right atlas, or I'm sorry, right vagus nerve. And so that's how we can have visceral issues that are going on that is caused from an atlas subluxation. All right, so we talked about the anterior atlas, how an anterior atlas can affect that vagus nerve, but we can actually have issues that are affecting the spinal cord based off of a posterior atlas. So whether it's an AS, RP, or LP, or an AI, LP, or RP, that posteriority of that atlas subluxation can actually hit the sympathetic part of the spinal cord, and I'll show you a picture here in a minute. But when it hits that sympathetic part of the spinal cord, that is going to cause Bell's palsy, or it can cause Bell's palsy. And so Bell's palsy is a hemiparalysis of the face. And so when a patient presents to your office with Bell's palsy, it's very apparent. The side that's being affected will have a droopy eyelid, a droopy mouth on that side, and then the musculature of that side that's being affected will be flaccid. So that entire side of their face is just going to be drooping downward. And so if we check here this picture, and I turn the camera off, or the light off so you can see, when the atlas subluxates and goes posterior, it can hit this part of the spinal cord. Now this is the ventral part of the spinal cord, which is sympathetic. So when it can go posterior, so if we had an LP in this case, it could hit that sympathetic part of the spinal cord and cause that Bell's palsy. Just like on the right side, if we had an RP and it hit this side, that would cause a Bell's palsy on the right side of the face because the cranial nerves run ipsilateral, right? So same side. So if we had an ASRP, that's going to come back posterior on this right side. It can hit that side of the spinal cord, the sympathetic part, and cause a right Bell's palsy. So the right side of the patient's face will be drooping. And that's how atlas, when it subluxates and goes anterior, it can hit that vagus nerve and can give us visceral problems that are going on. Or if it goes posterior enough, it can cause a sympathetic subluxation because it's hitting that sympathetic portion of the spinal cord and cause the Bell's palsy that we can see in patients. So that's how the atlas subluxates. But with the occiput, we're still working in the parasympathetic region. So any of our parasympathetic issues that we might be led to believe a patient has, if they're complaining of headaches that are bad when they're trying to go to sleep, but not bad at all in the morning, or if they have a hypersecretion of any of their glands, just parasympathetic problems that would lead us to think that there's a parasympathetic issue, that can also be the occiput. So that just about wraps it up, guys. We've covered everything on the atlas and occiput, from the misalignments to the anatomy, to the spinal nerves that are affected, and to the subluxations and how those happen to the capsular ligament. If you guys have any questions, just go ahead and feel free to message our Instagram page at PCCF_Gonstead Club, and we'd be happy to help you out with it. Stay tuned for more. Thanks, guys.